Slide 1. Calcium-calmodulin complex. Hello everyone, let's delve into the fascinating world of calcium and its interaction with calmodulin. Calmodulin, a regulatory protein, binds to calcium, forming a complex that activates enzymes like adenylate cyclase and K-dependent protein kinase. This complex plays a crucial role in regulating microfilament-mediated processes such as vesicle degranulation, endocytosis, and cell motility, all vital for cellular function. Now let's discuss some diseases associated with calcium imbalances, starting with hypercalcemia. This condition involves elevated serum calcium levels, often linked to hyperparathyroidism, where the parathyroid gland becomes overactive. A significant risk is the precipitation of calcium in the urine, leading to recurrent kidney stones. On the other end of the spectrum, we have hypercalcemia, a condition characterized by low calcium levels in the blood. Mild tremors can occur if calcium levels drop below 8.5 mg/100 ml. In severe cases, where calcium levels fall below 7.5 mg/100 ml, it can lead to tetany, a life-threatening condition marked by muscle spasms. Moving on, let's explore rickets, a disorder affecting bone calcification. This is primarily due to low levels of vitamin D or deficiencies in dietary calcium and phosphorus. A key indicator of rickets is increased alkaline phosphatase activity, which helps in diagnosing this condition. Osteoporosis is characterized by the demineralization of bone, leading to a progressive loss of bone mass. This condition primarily affects elderly individuals, especially women, after menopause. The resulting bone fragility leads to frequent fractures, a major cause of disability in older adults. The ability to produce calcitriol from vitamin D diminishes with age, particularly in postmenopausal women, increasing their risk of osteoporosis. Sedentary lifestyles contribute to bone mass decrease, while regular exercise promotes bone mass increase. Estrogen supplementation, along with calcium and vitamin D, can reduce fracture risk in postmenopausal women. A higher dietary calcium intake, around 1.5 g a day, is recommended for the elderly to maintain bone health. Assessing calcium status is a complex issue, especially given the public health interest in osteoporosis prevention. Currently, there are no reliable biochemical indicators for assessing calcium status. This is because the body tightly regulates serum calcium levels, even with varying dietary intakes. The skeleton acts as a large calcium reserve, making true calcium deficiency at the cellular level rare, at least for nutritional reasons. Slide 8. Serum calcium levels are tightly controlled by the body, making them a poor indicator of dietary calcium intake. This tight homeostatic control means that serum calcium is not a suitable biomarker for assessing calcium status. Altered serum calcium levels are rare and usually indicate serious metabolic problems rather than dietary issues. Low serum calcium levels can be caused by renal disease, acute pancreatitis, or hypoparathyroidism. High serum calcium levels can be caused by increased bone resorption, renal tubular reabsorption, or increased intestinal absorption. Urinary calcium levels are more responsive to changes in dietary calcium intake than serum levels. However, the association is still weak. Calcium output tends to increase with diets rich in protein and low in phosphate, and decrease with high-protein diets rich in phosphate. Slide 12. Let's shift our focus to zinc, another essential mineral with numerous physiological functions. Zinc acts as a cofactor for many enzymes, aids in wound healing, supports immune function, and is crucial for tissue growth and maintenance. Severe zinc deficiency can lead to hypogonadism and dwarfism as observed in the Middle East. To assess zinc status and estimate the risk of zinc deficiency at the population level, The WHO UNICEF recommends using 3 types of indicators. These include serum zinc levels, dietary intake assessments, and height for age measurements. Measuring serum or plasma zinc concentration is the best available biomarker for assessing zinc status and deficiency risk in populations. It reflects dietary zinc intake and responds consistently to zinc supplementation. Reference data are available for most age and sex groups, making it a reliable indicator. Zinc is a cofactor for about 300 enzymes and is involved in gene regulation through zinc finger proteins. It increases the expression of IGF-1, promoting growth and cell development. Zinc also stabilizes cell membranes and aids in wound healing and fighting infections. Zinc plays a crucial role in spermatogenesis, increasing sperm volume and count and improving other sperm parameters. It also improves thyroid function by aiding in the conversion of T4 to T3. Zinc is essential for pancreatic function and insulin release. In fact, zinc is co-secreted with insulin and helps in the stability and functioning of insulin. Insulin exists as a hexamer consisting of 6 insulin monomers and 2 zinc molecules. Once insulin hexamer crystals are secreted from pancreatic beta cells, they are believed to rapidly dissociate into monomers and flow into the bloodstream. This process is crucial for insulin's function in regulating blood sugar levels. Zinc levels regulate prolactin secretion, which is important for milk production and mammary gland development. Zinc also regulates thymopoietin synthesis, a hormone of the thymus that triggers T-cell production and regulates the immune system. Zinc directly participates in enzyme catalysis. If zinc is removed by chelating agents, the enzyme becomes inactive. Examples of enzymes that rely on zinc for their catalytic activity include alcohol dehydrogenase, angiotensin-converting enzyme, and carbonic anhydrase. Zinc can enhance or diminish catalytic function by interacting with another active site zinc atom or other metal. A molecule forms a bridge between zinc to zinc or zinc and another metal. Examples include zinc to zinc interaction in phospholipase C, zinc and magnesium interaction in alkaline phosphatase, and zinc and copper interaction in superoxide dismutase active site. Zinc atoms are required for the maintenance of structure and stability of enzymes. This is especially common to stabilize the quaternary structure of holoenzymes. Examples include nitric oxide synthase, protein kinase C, and alcohol dehydrogenase of vertebrates. Some proteins have domains capable of binding with zinc atoms via histidine and cysteine residues. Zinc finger proteins are an example. There are 2 classes of zinc proteins, metallothioneins and gene regulatory proteins. Metallothioneins were first identified in 1957 from equine kidney and consist of 62 amino acids with 20 cysteines. Metallothionine is a protein found in most tissues, primarily in the liver, pancreas, kidney, and intestinal mucosa. It holds promise as a potential indicator of zinc status, particularly when used in conjunction with plasma zinc levels. Metallothionine may be key to diagnosing metabolic zinc redistribution due to infection, trauma, or stress. Hepatic metallothionine concentrations rise with inflammation or stress, which also causes a rise in plasma metallothionine. High plasma metallothionine indicates redistribution of tissue zinc in response to infection and stress, not suboptimal zinc status. Low concentrations of both plasma zinc and metallothionine would indicate a reduction in the size of the exchangeable zinc pool as a result of a decrease in zinc intake. Acrodermatitis enteropathica is an autosomal recessive metabolic disorder affecting the uptake of zinc through the inner lining of the bowel. It is characterized by inflammation of the skin around bodily openings and the tips of fingers and toes, hair loss, and diarrhea. Several researchers have investigated that zinc in hair can be used as an indicator of body zinc status. Decreased concentration of zinc in hair has been reported in zinc-deficient dwarfs, in marginally deficient children and adolescents, and in conditions related to zinc deficiency, such as celiac disease, acrodermatitis enteropathica, and sickle cell disease. Because hair grows slowly, about 1 centimeter per month, levels of zinc and other trace elements in hair reflect nutritional status over many months and thus are not affected by diurnal variations or short-term fluctuations in nutritional status. Because of this, hair zinc levels may not be correlated with measurements of zinc in serum, which reflect shorter-term zinc status. Contamination of hair, endogenous zinc, rate of growth, and hair color are limitations of using hair zinc. Lower than expected concentrations of zinc have been reported in the urine of zinc-depleted persons. However, factors other than nutritional status can influence urinary zinc levels, such as liver cirrhosis, viral hepatitis, sickle cell anemia, surgery, and total parenteral nutrition. Problems associated with obtaining 24-hour urine collections can also complicate use of this indicator. Consequently, urine measurements of zinc are not the preferred approach to assessing zinc status.